Thank you. I must confess that, talking about surgery for upper tract disease is quite boring. There's only so many ways I can cut out the kidney and the ureter, and especially for this audience, I think I wanted to concentrate more on really discussing when can we skip the surgery and who needs more than surgery. My relevant disclosure here is that I'm a consultant and a PI for Stiba Biotech, which will come up later in this talk. So again, it's important to remember that upper tract disease, it's not bladder cancer, that radical surgery does not need to happen in everyone. And in a lot of cases, we undertreat our patients by surgery alone. Again, I'm not going to spend too much time on this. There is significant and important differences between urothelial cancer of the bladder and upper tract. It should be remembered that upper tract urothelial cancer is a Lynch-associated disease. And if you test routinely, you'll find Lynch syndrome in 10 to 20% of these patients, depending on the population and how you test. Clearly important implications in management, et cetera. Again, we haven't really changed our oncologic outcomes. If you look at the last 30 years, really haven't really made much progress, unfortunately. Again, I think low-grade tumors are probably undertreated by radical surgery. These patients do not need to lose their kidney. And a lot of patients with, high-grade, high-risk urothelial cancer probably aren't treated by surgery alone. So we do have excellent predictive capabilities. We have fantastic endoscopic tools. We can get tissue. There are imaging techniques. And we can put it all together to really predict somebody's risk of occult metastatic disease. There are nomograms. You can look it up. I'm not going to spend too much time on this, but there are ways to really risk assess these patients well. Again, as I've alluded to, radical surgery is not necessary for low-risk, low-grade upper tract urothelial cancer. We don't take bladders out for low-grade disease for the most part. We certainly don't need to take a lot of these kidneys out. In addition to fantastic endoscopic tools, antegrade resection, retrograde resection, et cetera, we now have FDA-approved therapy for low-grade upper tract urothelial cancer. I must mention here Jelmyto, which is a reverse polymer gel impregnated with mitomycin, meaning it's liquid at room temperature. If you insert it into a cavity and it warms up, it becomes a gel and releases mitomycin in a time-released fashion. So Olympus trial put the Jelmyto on the map with 58% complete response rates. And if you do achieve a complete response rate, it seems to be durable. There are problems with this agent. It's caustic. It causes scar tissue, scarification, and strictures. So there's some limitations and some know-how. However, we do have this in our toolbox. I wanted to highlight some interesting developments that are happening again and for low-grade upper tract urothelial cancer, specifically looking at photodynamic therapy. So this agent is derived from chlorophyll, has very short half-life. You can inject it intravenously, and as long as you shine the light on the specific wavelength, onto the tissue that has been exposed to this agent, free radicals are produced, and this takes advantage of abnormal tumor vasculature and the tumor's necrose. And so this is what we see after photodynamic therapy. You can see tumors kind of basically involuting, literally very low technical expertise. You need to just be able to inject this agent intravenously, literally put a laser in there and just shine the light in the vicinity, and this is the result. And so I'm fortunate enough to be the PI in what's called an enlightened clinical trial, where patients for now with low-grade upper tract urothelial cancer get 3 sessions of photodynamic therapy. They get assessed for complete response as the primary endpoint of this trial, and then they can have maintenance sessions. So this is very, very exciting. I cannot share yet the intermediate results of this trial, but I can tell you this works, and this will be an excellent addition to our toolbox for some of these patients. We're designing clinical trials that we will start looking at high-grade, high-risk disease combined with immunotherapy. So finally, we have some interesting things that are happening in the field. Conversely, I think, just yanking these kidneys out is probably not enough for patients with high risk for occult metastatic disease. The POUT clinical trial, I'm not going to spend too much time on this, but has taught us that upper tract urothelial cancer is a chemosensitive disease, and especially this trial was done in an adjuvant setting, and finally showed us that there is There are improved survival outcomes in patients treated with platinum-based chemotherapy in an adjuvant setting after nephroureterectomy. However, if you take, these are elderly patients, and if you take their kidney out, a lot of these patients simply will never have an opportunity to get chemotherapy again. So I think by the time we're talking about adjuvant treatment in this patient population, and especially if you consider using platinum, we have missed the boat. I was fortunate enough to be involved in ECOG 8141 clinical trial, where we asked the question, well, can we give platinum-based chemotherapy prior to surgery, as is the standard of care in bladder cancer? Here, we've leveraged dose-dense MVAC for 4 cycles prior to nephroureterectomy. This trial read out a few years ago, and it's been reported. The bottom line is this can be done safely. All patients went on to have surgery, and not surprisingly, there's significant complete response rates and significant rates of downstaging. So neoadjuvant chemotherapy, especially high-risk patients, is possible, safe, and should be on your radar. Building on this trial, and together with Jeannie Sensitz and Petros Grivas, I'm also fortunate enough to be involved in the follow-up clinical trial, where we're now randomizing patients with good GFR to get dose-dense MVAC and durvalumab, or dose-dense MVAC alone for the good GFR arm. And in patients with poor GFR, we'll get durvalumab and gemcitabine. And this trial is ongoing. This is an intergroup trial, so please make sure to have this on your radar. So how do I manage, to conclude, how do I manage my patients with upper tract disease? Patients, we attempt to have complete endoscopic removal, meaning retrograde or antegrade resection. For low-grade disease, patients will probably go on surveillance or adjuvant therapy. Patients with small, non-invasive, high-grade disease will have a second look, a ureteroscopy, to make sure all of the disease is gone. And in a lot of cases, these kidneys can be preserved. Patients then can go on to adjuvant treatments with Jelmyto, et cetera. Patients with high-grade, high-risk disease, especially if they have high-risk features, are channeled to clinical trials, or at least offered a neoadjuvant platinum-based systemic chemotherapy, followed by surgery, consolidative surgery. Patients with no high-risk features and patients with predicted good GFR after surgery, meaning that they can get platinum after their surgery, will go on to nephroureterectomy alone, followed by reassessment of that pathology. And if high-risk features are present, these patients still have good GFR and still can get platinum in an adjuvant setting. So that's sort of in a nutshell. Again, I don't think, I think we've squeezed everything out of surgery. And I think really to move the field forward, we really need to consider, how do we make surgery more effective and who can avoid surgery in the first place? With that, thank you very much. And I guess we'll take the questions later.